Hello, my name is Dan Nalen. I'm the Senior Vice President of Broker Relations at Payer Compass. I'm very excited today to be able to present a case study with my friends David and Amanda. We have now collaborated on a case that we're going to represent to you in the next few minutes, and we're going to basically talk about what's different and how this case went together as more or less a case study for how does a program go together with Payer Compass, with a broker, with a third-party administrator. So, David, if you just take a few minutes to give us a little background on this case and kind of where you started and how it's going to evolve and kind of the thinking behind your decisions.
Sure. So this is a commercial real estate manager and brokerage firm. And kind of, I don't know if it's unique, maybe it's a little more common today, but some of the challenges that we had in going to a no network style plan was that they really are very distributed. They have two headquarters office buildings that exist in two large metropolitan areas, but of their about 800 members, there's really no more than 40 or 50 in any one geographic location, and some have just one or two or three. So we had some challenges, and what I did to try and address those challenges was to speak to the repricers that we're comfortable with and say, who has the most in-depth claims experience in the markets in which these employees exist. I want to see the percentage of hospitals that are pushing back or not pushing back. I want to see where the balance bills are occurring, how frequently they're occurring, and how they're being settled. And I want to use this data to find the ones that have the best name recognition and the most knowledge on those individual markets. And secondly, and perhaps most importantly, our entire healthcare system is getting the results it's getting for a very simple reason. We overcomplicate this. We throw a lot of names at it. But at the end of the day, if you look at how brokers are paid in general, how insurance companies make money in general, how doctors and hospitals are paid, how drug companies are paid, and how PBMs are paid, you'll understand that they make more money by costs going up. A lot of people don't understand that. And so that's why costs keep going up every year. I mean, it's really that simple. And so we change how people are paid. It started with how we're paid by our clients, and it extends to all the partners and vendors that we bring in to build a health plan for our clients. And so we want to, at worst, remove the perverse incentives that exist across the board, and at best, realign those incentives. So once we could see a couple of the repricing partners that had the most knowledge in those areas, we then looked at how are they paid. And what became clear to us for this client was that Payer Compass was the best solution because of their depth of knowledge in the markets where they had employees, and because they're paid in a model in which higher cost doesn't equal more revenue to them. And in fact, it's actually in a way where they're more incentivized to help keep the cost down. So when we realign those incentives and we get everyone working towards the same end goal instead of fighting each other, you're just more likely to achieve the results that the client is wanting.
Very good. Thank you, David. Appreciate that. So your success is really dependent on the TPA because David's a guy that has lots of great ideas, but he needs an implementer. And so he leans on people like the Coastal Administrative Services, people like Amanda, to actually implement all these great things because they're really the connecting point to the client. So Amanda, talk a little bit about this case from your perspective.
Absolutely. In working with David and on his groups, again, like he mentioned, we're really trying to create a really healthy ecosystem that benefits the plan and the member. And all of that actually starts off with just proper education, because again, they're coming from a traditional PPO side where they don't get, understand the nuances of this new program. It's not meant to be scary. It is actually very effective as long as they are prepared of what's to come. And that happens on, again, two different levels. Obviously, the HR level, who is going to be hearing and communicating this information to their membership, but also really empowering the member to understand each of the different phases of an open access plan. So in taking all this information, I think that what really is important is to understand and meet the members where they're at with this process.
Very good. So, Amanda, if you don't mind, you and/or David can answer this question. You know, member education is incredibly important, especially when you're changing the dynamic into something like reference-based pricing. Explain to us, A, how you set that up, David, how you explain that to the management people, and then how you get the members to buy in and how you get the process. Because This is all about the member experience. How do we manage the member experience, David?
So one of the things that Payer Compass has done really well is that they've culled information just based on experience as far as which providers are not pushing back against reference-based pricing at all, which ones are kind of hesitant about it but accepting it, and which ones are just actively pushing back. And one of the things that employees ask for all the time is, well, is there a list of doctors I can go to? And in our model, that list is the phone book, essentially, right? Because you can go to anyone you want to go to, but we recognize that some are going to give a little more resistant absence a contract. And so there's a few things that we do to mitigate that. First of all, we prioritize providers that are either transparently priced or willing to give us a fair, reasonable contract. The way that we prioritize those providers, which completely eliminates all the friction of reference-based pricing, is by waiving out-of-pockets when members go there. And we directionally improve the quality of care and lower costs. And Payer Compass supports this because, again, if they were paid, let's say, 1% of the original claim, what's their incentive to push us to where they don't have to reprice the claim at all? There is none, right? They have an incentive to not support that. But with Payer Compass being paid a per employee per month, they have no reason to not help support that. And so the engagement that we get, pushing members into areas where the costs are lower, the outcomes are better, and all the friction that people are so afraid of around reference-based pricing is completely gone, they help support us in that. At the member education level, and it's funny because I had a prospect call just right before this where I enlightened this group of executives to how doctors are paid, how insurance companies make money, and how this results in really low clinical outcomes. But most of America is not aware of that. They think we have a really high quality healthcare system. They think it's fairly priced, even though it's expensive. And so educating them on the fact that there are good doctors and there are bad doctors, and we have data that can show them. And Payer Compass helps us get that data. Payer Compass also helps us when we find the provider that we want to engage to help us negotiate the terms and get that contract in writing. So now it's a contractually obligated process to see that patient. So these are all the things that play into it. And when you do all these things right, the noise around reference-based pricing becomes similar
almost
in volume. Yes, similar in volume to the noise around regular plans. The only challenge that we deal with is that people have come to anticipate the noise in a traditional plan, like surprise bills. How is that any different than balance bills? As a matter of fact, the surprise bill rate nationally is higher than our balance bill rate is in our reference-based pricing plan. But isn't that really just a surprise bill, a balance bill? So there are things you can do to mitigate that and further increase the quality of care and the savings.
David, very, very well said. We appreciate that. So, Amanda, it's your job to go out and help educate the members, and the members are calling you. They're not calling David. How does that work at your end?
Absolutely. Well, we always like to say that TP needs to be that quarterback because we have all this information. We can do insurance verification. And what, again, is great about Payer Compass is the provider nomination form to be more proactive than reactive in this type of situation. So we mitigate those phone calls. It's a point of education at the time that they call us, where we can then forward this information to Payer Compass so that they can do their job and connect with the provider so that they can get to provider negotiations. So it really is a streamlined process, again, starting at point A, ending at point Z. And anywhere between the phases, if a member does not know, has my provider accepted this plan, they always will come back to say yes to get that answer. However, we're always working and integrated with Payer Compass to get to that resolution.
So how has that experience been? Tell me about your experiences with Payer Compass as far as our staff and personnel.
Absolutely. Well, beginning from implementation, it has been phenomenal. I know that there are a lot of key points into, again, integrating new systems, but it has been fairly easy to communicate with your team. You guys also have a patient advocacy team in which David mentioned that we can connect with at any point in time. And from a member perspective, that's important because members in this type of process can't be left in limbo. They want to know where their case is at, what's happening, where's this balance bill going, where's my provider access issue, is it being resolved? So in terms of the communication, it has been an ever-flowing, constant conversation between the two parties. So very streamlined and efficient.
Excellent. Very good.
Yeah.
David, how do you see this evolving into the future in terms of where this goes in the education process? You said you had a conference call a little while ago with some providers. Where did you leave that? In other words, where's the future opportunity for this, and how do we do a better job bringing this information into the marketplace in a more robust way?
Well, I think there's a few things that need to occur. First and foremost, we need to educate employers to understand that they not only have the most to gain or lose, but they actually have the most amount of leverage in the healthcare system. They think they have the least, but they actually have the most because they're the ones ultimately footing the bill, and cash is king. They drive where those dollars go, even though they're putting that out to a third party that's driving it to where they want it to go. If they took control back of that and they said, no, we're going to redirect this intelligently, it changes everything. But a lot of people think reference-based pricing is about taking advantage of the providers, particularly the hospitals. And that's not the case at all. If you really start to understand payment methodologies in healthcare, and it's a complicated thing that took me many, many years to fully understand, you'll understand that there's a really high cost to collecting for hospitals in the current environment. And that cost comes really in a few different ways. It comes from the fact that out-of-pockets have gone up and up, and most hospitals write off somewhere around 75% of patient responsibility. So they're writing off thousands of dollars per inpatient admission every single time. That's pain point number one. Pain point number two, I've done some back of the napkin math, and I estimate that United Healthcare doles out somewhere between 10 and 15 billion dollars a month in claims nationally. With a B. Right. If they're to float that money for a month or 2 months or 3 months or 4 months, the interest they collect on that float is tremendous. So they're slow playing, paying providers more and more and more and more to collect that float. Then you add in the complexity of billing. And again, I don't know how many people get into this, but we just switched a couple of years ago from ICD-9 to ICD-10. That one digit increase meant millions of additional codes. There is now a code for someone who is kicked in the stomach by a horse while in prison. Don't know we need a code for that, but it exists. So the complexity in billing, and then you add in the complexity in medical management and pre-certification, the overhead tied to collecting money is huge. So what if we were able to minimize that? Maybe not eliminate it, but reduce it by 90%. If they're spending 40 cents of every dollar to collect that, and we can cut out 30 of that 40 cents, then why can't they give us a lower rate than Blue Cross and United and Cigna and Aetna and still be more profitable on that money? If we eliminate out-of-pockets, if we promise to pay them within 30 days, these are really big carrots to hospitals. And so there's actually a path that allows us to pay substantially lower reimbursements and still have the hospitals be as or more profitable on that lower reimbursement. But getting them to understand that is often the hard part.
So David, you just, you articulated a big issue here. How does Payer Compass integrate into that process, and how does that work for you and Amanda and myself and the team at Payer Compass so we can take that conversation? Payer Compass administers over 100,000 direct contracts today. We don't hold any. We're not a network, but at the end of the day, people like you can actually go out and create contracts and use Payer Compass to administer them. Let's talk a little bit about that, if you don't mind.
Well, I had to become an expert at developing contracts because no one else was doing it for me, at least not in a way that I would sign the contract if it were put in front of me. And so the biggest difference with Payer Compass, because they're a more recent partner of ours, has been I get emails all the time that says, hey, this member went to see this provider. They had trouble getting in. We've already initiated contracting conversations. And even more impressive, this week alone, I had 3 come to me from Payer Compass to consider for me to advise whether or not the client will sign it. One of them was exactly the way I would have designed the contract. I mean, it was spot on, perfect. I've never had that come from a repricer before. The second one was a hybrid between the two. It had some of the features I liked, some I didn't like, but I ultimately recommended the client sign it because it's just a single case agreement and this person needs care. And then the third one, I could tell the payer Compass had tried. It wasn't the fault of theirs, but they were just saying, we'll give you a 15% discount off bill charges. And by the way, we typically only give 5%, so you should be lucky. And my response is, well, what's the bill charge going to be? Knowing they're going to say, well, I don't know. I'm like, well, if you can't tell me that, your discount doesn't mean anything. And so I recommended we not sign that contract. Here's the thing. If more employers did that, if they actually made a dent in that unwilling to cooperate hospital's bottom line, what is that hospital going to have to do? They're going to have to change. See, employers are not just the key to fixing this for themselves and their employees. They're actually the key to fixing this for the country. If they collectively stood up and did these things, the whole system would change.
Great. Awesome. Thank you so much, David. Amanda, you're a TPA that has to administer all this. Where do you see this going with Payer Compass? You have other clients, you have other opportunities, et cetera. Now that you've engaged with us, are there other opportunities out there you can see where this is going to fit?
Oh, absolutely. Absolutely. And again, like I said, we talk about our partnership and the ease of administration and communication between partners, and knowing that I want to point out two other different products that you guys have that was really impressive on my end. Obviously, you have your Compass Connect tool that really empowers members to obviously take action for themselves, aligned with the incentives that David mentioned of, let's get you into a reference-based price friendly provider so that you can achieve this goal. That's going to be really key in pushing this forward to the future, is that there are tools and resources available for members to actually access that. And then obviously your balanced bill support, and that right there in itself proves to be a really good product so that members don't have that anxiety over balanced bills. They know that there's going to be protection on that side. So there's so much, again, collaboration, protection that will help employer groups really take on understanding open access plans a lot better. So it is going to be very much the wave of the future, and just having that conversation and education to allow them to take it on.
Very good. Well, we really appreciate you guys taking a few minutes to enlighten us as to the perspective that you have on Payer Compass. In the Health Rosetta space, Dave Chase and Sean and those people, they're working through a process here to try to make this more or less a universal. David, do you want to take a minute just to kind of say how this applies in the Health Rosetta world? And Amanda, you might want to chime in for a minute. And we'll kind of close with this discussion. So another 2 or 3 minutes, we should be good.
So listen, Health Rosetta was established and the reason it's called Health Rosetta is because the Rosetta Stone was the key to us deciphering the Egyptian hieroglyphics. We didn't understand the writings on the wall until we found the Rosetta Stone, and then with the Rosetta Stone, we could instantly understand and decode ancient language. What Health Rosetta sets out to do is the same thing in health plans. A lot of people think that it's complicated, and I'm tired of hearing that, but I hear it all the time. So we need something to decipher. So what Health Rosetta did was they said, wait a second, we know Walmart, the largest employer in the country, is doing some things well. Tom Emmerich, who many of us know, was sending people to centers of excellence for those high-cost, infrequent procedures. Harris Rosen at Rosen Hotels was doing on-site clinics and direct contracting for pharmacy. So what Health Rosetta said is, what if we could first off validate that these point solutions are working? What if we can then bring together ideas from here and here and here? And then what if we could scale it and replicate it so that small and medium-sized businesses could take advantage of these things? So that's the premise of Health Rosetta as a whole. But what's coming out soon is an ability for us to take a plan and then pump in some data and say, how does your plan rank against traditional plans, against reference-based pricing plans, against other Health Rosetta plans, and now start to really be able to score a plan to then measure it, to then improve it. And that is going to be coming out very soon. But it's really an entity that is meant to say, we have a map. It may not be the right map for you, but we have a map and we know it works and we validated it and we're willing to share it if you're willing to listen. That's really what it's meant to do.
And Payer Compass is an integral part of that process because we are one. It's like a big jigsaw puzzle. David basically is going to measure jigsaw puzzle against jigsaw puzzle against jigsaw puzzle. the Payer Compass will have a piece of each one of those because the way that we manage data, et cetera. Amanda, anything you want to add to this conversation in closing?
Absolutely. I mean, just to come up from David's conversation, it's really bringing healthcare consumerism back into the hands of the members, right? What we want them to know is that they have a choice. And with aligned partners and just the right education, the right team, the right workflows, it's an ever evolving and changing landscape. So how can we remain flexible and really make changes once we see that new thing come, and how do we make quick resolution? So again, at the end of the day, it's all about those members and empowering them to make the best decisions possible for them and their families.
Great. Well, on behalf of Payer Compass and Health Rosetta, thank you both for spending some time with us this afternoon. And I think this has been very enlightening. David, thank you for your comments. Amanda, thank you for your comments. And we hope to see all of you at Health Rosetta in the future. Thank you very much. Have a great day.